Provident Healthcare Partners is a healthcare investment bank that is focused on transaction advisory services. We created this podcast for healthcare executives, entrepreneurs, shareholders, and providers who are interested in learning more about the world of healthcare consolidation.
Good morning, everyone. Thanks for joining us here on another episode of Provident Perspectives. This is Craig Sager, a director here at Provident Healthcare Partners. Today, we are going to be talking everything behavioral health and specifically substance use disorder and eating disorder, which is obviously a huge topic as we think about behavioral health more broadly. We have a few special guests with us today from Sanford Behavioral Health, the leading ED and SUD provider in Grand Rapids, Michigan. David and Rae, how you doing?
Great.
I'm doing great, Craig.
Awesome. And my colleague, Dan O'Brien, who is an associate here at the firm and leads our efforts within SUD and ED. Provident Healthcare Partners, behavioral health is one of the main verticals that we spend our time in working with clients and just broader research. So we have some really interesting topics for the audience today and really excited to hear the story of Sanford Behavioral Health and the waters they've navigated. But first, we'll kick over to my colleague, Dan, to get a quick perspective and overview on SUD and ED as it sits today.
Thanks, Craig. Just by way of background, I'll give a brief introduction of myself. I've been with the firm going on 3.5 years now. And as Craig mentioned, I would say the vast majority of my time kind of canvassing the addiction treatment and eating disorder spaces within Provident's behavioral health practice. I'm recently located at a Providence, New York City office down in Manhattan, and I'm excited to kind of kick things off today.
And Dan, could you just, for everyone, in terms of what we're seeing in the market, why is specifically substance use disorder and eating disorder getting so much attention, whether that's from investors, that's from operators starting their own companies, just the broader ecosystem?
Yeah, can briefly touch on that to get things kicked off. The addiction treatment and eating disorder space, I think, is unique as it sits within kind of behavioral health services. It's certainly an area where we've seen accelerated investor interest over the past, I'd call it 5 to 10 years. There's been 50 plus private equity platform investments being made into the sector over that same time period and over 200 distinct transactions being executed. This is for a multitude of reasons. I think the headline being that there's a persistent supply and demand imbalance that we're seeing within the sector. And partial with that, there's also an increasing government and commercial insurance coverage and additional dollars being spent to fund some of those resources in the sector, making it a more, I would say, emerging and nascent area for investment for healthcare investors. And then the last is that it's still an area where we're seeing a high amount of fragmentation. Not a lot of, I'd call it, large industry dominant players that are responsible for the vast majority of the market share. We're still seeing a lot of mom and pop practices that are maintaining their market share and continuing to grow. And I would call it a healthy market.
Yeah, it's certainly an evolving and very dynamic space. And so with that, would love to turn over to David and Rae Green, the co-founders of Sanford Behavioral Health that we profiled earlier. Just for the audience, Sanford is based in Grand Rapids, has over 250 chairs and beds combined, approaching 200 employees, a business we think highly of, has a great reputation in the market. David and Rae, I know we're going to hit a number of topics today, but I think first we would love to hear your personal stories. What got you into the space, and really just a quick overview on Sanford would be great.
Hey, Craig. Just a little background on us. Rae and I both started out as lawyers. In my case, I was at a large law firm for about 4 years and pivoted into business and was involved in resort construction in the Bahamas, port of calls for cruise lines, ended up founding what's become a pretty well-known school there called the Island School on the island of Eleuthera. Was involved in the car dealership business, a lot of real estate in Grand Rapids, and professional sports teams, minor league hockey, arena football, really throughout the country. And Rae ended up transitioning from law to being the executive director of a number of nonprofit organizations. And about 15 years ago, decided to get her master's in addiction counseling, which she did. She worked for a couple of larger organizations, ended up running a nonprofit Medicaid-funded women's center in Grand Rapids. And she was approached by women who had been to Sierra Tucson or Betty Ford, and they said, I want to volunteer my time at your facility here in Grand Rapids. And that was what we call our light bulb moment. Rae said, why are people leaving the state of Michigan to seek treatment across the country? And we did our due diligence and we realized that Michigan at the time was quite behind in behavioral health, including substance use disorder. There was an extreme paucity of treatment stays where 5 days, maybe like a revolving door situation. And with that knowledge, we decided to open up a 10-bed women's center in Grand Rapids. And we, at the time, thought we were going to do private pay. We renovated a 1847 home, beautiful home, into a 10-bed women's facility. And what we found was Michigan, West Michigan, is not a private pay culture like other parts of the country. So we quickly pivoted into the world of insurance. And at the time, we're primarily out of network with the insurance companies. We knew we wanted to do the same thing for men's. There was a shortage of men's services in Michigan as well. And 2 years later, so in 2017, we opened a 20-bed men's facility in another historic home in our historic district here in Grand Rapids. And that went very well. A year later, we started an outpatient center for substance use disorder and started seeing a big need to bring on detox. We had the full continuum of care, but we didn't have detox. We did use other facilities, but it was a bit challenging. We really wanted to control the quality and the full continuum of care. So we started looking to real estate to bring on the detox. At the same time, we'd been talking for a number of years about doing eating disorder treatment, primarily because in our women's center in particular, we would get the substance use disorder, what we'd call under control, so to speak, and eating disorder would oftentimes pop up. If you really look at the data, 50% of the people who go into eating disorder residential have a substance use disorder co-occurring condition. So we ended up buying a 100,000 square foot campus, 15 minutes from downtown Grand Rapids. We did it at the beginning of the COVID pandemic, which created a lot of interesting challenges. And we then grew our vision from substance use disorder, eating disorder, to really realizing fundamentally we're in the mental health business. And there are a lot of different diagnoses that go along with that. And in consultation with some large insurance companies, we realized there was an overriding need for mental health primary. And so after opening up substance use disorder with detox here at our campus and eating disorder, the first and only residential eating disorder in the state of Michigan, we now are completing our programming with primary mental health.
So I'd like to add just a couple of things. Is when I was back in the mental health area of Medicaid and the nonprofit that I worked for, what we saw was that those services were relatively well funded, but it was the commercially insured or the private insurance that were the underfunded population here in the state of Michigan. And for those listeners that may not know the geography here in Michigan, beautiful Grand Rapids is on the west side of the mitten, and we're about 3 hours from Chicago and about 2.5 hours from Detroit. So we're well positioned for statewide services. And we launched this with the idea of providing quality care, a little more long-term than we were seeing. But again, it went back to that commercially insured, underserved population.
That's an awesome overview. And I think we, two lawyers turned entrepreneurs, would love to hear it. And obviously, what you guys are doing for the community up there is incredibly noble. And I think what gets Dan and I excited about Sanford and businesses like Sanford is, and again, geography certainly matters in any industry, but really so in addiction treatment and eating disorder, is for a period of time, they were out of network, but, made that conversion to in-network. as David, mentioned, they offer the full continuum today. And so when we cover the market from a research standpoint, it is more rare to see a model like this, which we believe where the industry is going. So we have a ton of respect for what David, Rae, and team are building over at Sanford. Parlaying that into what I think is a really important topic as it relates to Sanford, but also just the industry more broadly, is this topic of out of network and in network. The Sanford team has shifted nearly entirely 100% to an in-network model with the payers in their geography. And I think when we look at things in the market, that's not always the case with groups we talk to. So Dan, on this topic, could you explain just for the listeners, just the basic differences between out of network and in network? We know that in mental health and addiction treatment, there's a much higher utilization than other parts of healthcare here, and for specific reasons. If you could hit on that, that would be super helpful.
Yeah, happy to. So I think unlike other areas of healthcare, for many years, we've seen the addiction treatment space and eating disorder space was predominantly, at its outset, a cash pay or more of a private pay reimbursement model, probably related to things surrounding stigma and ultimate responsibility on behalf of the patient on who's, kind of responsible for providing and paying for these services. However, really with the onset of the Affordable Care Act, we're really beginning to see more and more insurance plans either offering or being mandated to offer at least partially coverage for some of these addiction treatment and also broader behavioral health services. Kind of the legacy approach, this out-of-network approach, is really the crux of it is that the provider is able to set their rates and charge the patients kind of the stated amount or what's ever listed. However, in this case, the insurer is not obligated to cover for the services that their provider is actually charging them. And so the delta here, the cost that's not being covered by the insurance, is ultimately passed on to the patient, which can ultimately lead to potentially poor outcomes for the patient post-treatment. However, in an in-network model, there's a preset arrangement or a contract that's set in place between the provider and the insurance carrier, which allows for these services to be covered in full and removes any prize billing or unforeseen costs that may be passed on to the patient post-treatment, which ultimately we think could potentially lead to better outcomes for the patient coming out of their recovery stay. So obviously, this has many implications for providers, for insurance companies, and for patients. And navigating this can be difficult for providers within the space as they kind of look to kind of establish which strategy or approach to insurance contracting they're going to take for their business.
Well said. And I think translating that over to Sanford Behavioral Health, David and Rae, you guys made a decision a number of years ago to flip the story on this from an out-of-network model to an in-network model. Would love to hear why from your kind of vantage point and how you did it just more logistically.
There's a number of reasons. Let's start with the patient. In an out-of-network contract or situation, the patient is paying an extremely high deductible that oftentimes does not cross-accumulate. So it doesn't, in other words, it doesn't go towards their annual deductible. So it's kind of a burn deductible, and it's very expensive for patients. And oftentimes patients in our world do not have the financial resources to support that. I mentioned first that I think Michigan and maybe the Midwest does not have a huge private pay culture, which other parts of the country may have. So first of all, it's trying to ease the burden, the financial burden on patients, and also get them into your care. So from a pure business standpoint, in 2016, I think we were at a conference and it was pretty elaborate. It was a very famous hotel. And I looked at it and I said, I am not sure the out-of-network high payments, the high reimbursements are really sustainable, because ultimately insurance companies are pretty guarded with their resources and they're relatively smart in managing those resources. And why wouldn't they go work on in-network contracts where essentially you're trading that big out-of-network fee for a negotiated smaller fee, but you're working on a little more volume, right? You were going to be listed in their in-network program. Theoretically, you can lower some of your marketing expenses. But I think probably the most important thing, in addition to the positive impact on patients and the access to care through an in-network arrangement, we have become partners with those insurance companies. Not every one of them, but we literally sit down and we talk about new medicines that are available, how we can improve the treatment, how we can improve the utilization review process, what programs they would like us to open. The primary mental health that we are in the process of opening right now, that came out not only of us analyzing the market and realizing there's a lot of empty space between psychiatric hospitals and what is akin to adult foster care treatment here in Michigan. But we are able to work with the insurance company, identify the need for that and their willingness to pay for that, and potentially pay a premium for it because it doesn't exist. So there's a lot of different aspects to why we went in network, but I would say fundamentally, I did not see the out-of-network model having long-term financial sustainability given healthcare costs in the United States and where I saw insurance companies headed with this.
No, it's a really interesting dynamic. I think you hit the nail on the head, David, where it's very challenging for groups we speak with and just throughout the market where they're out of network. They have these, what I would say, awesome high rates, and to flip to lower rates, even with potentially expected higher volume, that's a hard pill to swallow. But obviously you guys have taken that and doing things the right way here. I guess in terms of clinically, Rae, has the conversion changed anything of how you guys operate or the end population, just kind of from a day-to-day operational standpoint?
Yeah, it's really had positive impacts, Craig. It's changed in that we have been able to create a continuum of care that is supported by in-network insurance coverage. And what that means is that we can admit clients into treatment at the level of care that aligns with their needs, and that care can evolve with the patient over time. So working hand in hand with the insurance company, providing those utilization reviews, we can talk about where that patient is at and what their needs may be. And our clinical team, our therapists can say, what are my priorities right now at this level of care, and how do I get them to the next level of care? So it's a good model as far as being able to provide everything in-house and also longevity. And we know that with full continuum of care, there's a reduction in recidivism rates amongst those with substance use disorders. So being able to provide that levels of care, and I could talk a little bit more about that clinically if you'd like me to.
Yeah, that'd be great.
Okay. So what it's like is when you talk about a continuum of care and matching the ongoing needs of a client, we're kind of like a taper, moving a client from, let's say, residential through outpatient through the system. This system often begins with a medical detox, a subacute detox. That's a process where we can now in-house safely detox patients from their substance of choice. And as a therapist, I can say that, successful therapy only occurs when the body is medically stable and free of that substance or this physical dependence on that substance. That can be a 3-day stay, a 5-day stay, a 10-day stay. And that really gets us off to a good, solid start. And then you've got your residential care, which is a pretty intensive 24/7 monitoring and support, including a lot of individual and group work and therapy and counseling. But along this path, our team can craft a really personalized treatment plan that adjusts to, the unique needs of each client. And the goal clinically is that these individuals receive the right level of care at the right time. And so after the completion of a residential stay, again, working together with those in-network providers to say, where is this client at? And looking at all dimensions of this client's life and world, such as, what is their home life like? So we not only where is their disease at, but what is their home life like? So we move from residential then into what we call outpatient care, where the patients are no longer residents, and PHP, which is a day programming, partial hospitalization program, high intensity day services without around the clock attention of residential care. However, we do have, and this is a real benefit, is we do have supportive living here with the programming for those who maybe don't have a safe environment to return to or who live far away. And then you've got your intensive outpatient model, which is more moderate intensity. And the beauty of this is that it takes place before or after work or when someone's in school. So easing someone back into, quote unquote, I'll use air quotes here, real life. And so we are able to treat all facets of the disease, with a more unified model, which results in more positive long-term outcomes.
Appreciate that overview. And I think that's really helpful for the listeners. As you built out your continuum, and as David alluded to earlier, maybe add on detox later into the process, what order did you go in? Was it you started with the residential and then you saw patients leaving and you adding an outpatient made sense? Or how did that work and all come together over the years?
Thanks, Craig. That's a great question, because we started with residential because that's where we saw the highest need. But what happened is that we saw people who were coming to us who weren't medically stable. And so we were sending them to the emergency department or another detox facility. And sometimes that gets a little cumbersome with bureaucracies and placing people back and forth with their insurance as well. So the detox became a real necessity, but also outpatient, because not everyone can leave their job or their home. And so we can have a more intense outpatient program. And there also is another pretty important consideration, and that's the consideration of relapse. And when someone relapses, which can happen in this disease, as it does with others, diabetes, heart disease, relapses can occur, is that we can put someone back into a step-up level of care, transition them back to that level of care. So what it allowed us really was more flexibility. And what we tried to do with this, Craig, was reimagine how the behavioral health care system can be delivered, collaborating and seeing an optimization of outcomes by having more flexibility. And I think Dan used the word fragmented earlier. That's what our care initially felt like, was a little fragmented, just having that residential piece. And so adding all of these other lines of care has given us just the luxury of being able to adjust to each client's needs as they come.
Right. A big theme within behavioral health, but specifically to what Sanford does, is just co-occurring conditions. And David mentioned earlier that recognition with running the Woman's House with the eating disorder. When you think about your subline of the business, your eating disorder, you guys potentially rolling out a mental health psych program, could you just speak a little bit to what you're seeing day to day through your patient population, why having those three legs to the stool makes sense?
We've really transformed our thinking about how we deliver care. And we have a saying, we call it psych first. The acuity level of the patients that we are seeing coming in for substance use disorder. And when I say acuity, yes, there's a substance use disorder, but from the pure psychiatric mental health perspective is much higher. Certainly when we began in 2014, 15. We did not have the resources. We did not have a full-time psychiatrist. We didn't have psych nurse practitioners. We didn't have other medical providers. And we would not be able to operate that way in this environment. The folks that we're seeing, 97% of them have some sort of mental health diagnosis. And it could be something like anxiety, right? But there's also a lot of more acute psychiatric diagnoses we're seeing. So we're psych first. We literally have our psychiatrist or nurse practitioners see our patients on day one, and we try to address the mental health issue as they're entering into the substance use disorder treatment or the eating disorder treatment.
So what this does is it really eclipses a co-occurring model. Co-occurring model says we're going to treat the substance use disorder and the mental health underpinnings that go along with it. But we have changed that to looking at the mental health equally, or getting the substance use treated and then focusing on the mental health. And as David said, the pandemic catapulted us into this because we really had to more adequately address mental health. Part of what happened to the world is that awareness of mental health became really a part of the human condition. So just as we strive for physical health, we're seeing people looking for mental health treatment.
Yeah, I think it's clear your approach operationally, clinically, from a leadership standpoint is incredibly thoughtful and really serving the patient wholly, right? And think when we say continuum of care, what you guys are doing is certainly that. So Dan, I'll flip it over to you. When we think about the investing community and folks that, the non-operating folks looking into businesses like Sanford across the country, from a out of network versus in network profile, and then also having a full continuum versus maybe only certain parts of service offerings, what are you seeing? How is it viewed?
Yeah, sure. Happy to touch on that. From the investor perspective, ultimately, investors and buyers alike are looking to partner with groups who are playing a role in managing the cost curve, right? Because they're valuing the sustainability of a business and ultimately what that means for a patient and their clinical success. On an out-of-network basis, from a financial perspective, there's a lot of unpredictability as it relates to the collection cycle, and you're ultimately managing your revenue, right? You could have a lot of outstanding accounts receivable as you look to chase down payments from patients or the insurance companies, because ultimately there's not that contractual obligation to reimburse on that billing. And as groups transition to an in-network model, ultimately what you're gaining is not only is it a supposed increase in patient volume, but it's also that predictability and recurring nature of some of those billings, where ultimately might have a short-term, say, lapse in profitability because you're not being reimbursed at the same level on a per patient basis that you were previously on an out-of-network basis. In the long run, as volumes increase and ultimately as you renegotiate rates with those in-network contracts, profitability should come in the long run. And that's really ultimately what buyers are valuing. It's that predictability of this revenue stream. And from the continuum of care perspective, what buyers are valuing when we talk about capturing more of this patient journey, and Rae touched on a lot of the success that this brings from a clinical perspective, but ultimately from a financial perspective as well, you're able to increase the services that you're able to bill for, right? If I'm a full spectrum treatment model, I can bill detox through outpatient services. And then obviously in Sanford's case, they're layering on some of these ancillary services like eating disorder and primary mental health, which from a downstream perspective are attractive, I would call kind of ancillary or add-on opportunities that you're also able to kind of capture and bring more of these services in-house, really removing the need to send these patients elsewhere, which could have not only a drag on your bottom line, but also more importantly, potentially a shortfall in clinical success. So those are really the kind of, I would say, from the investor's lens, what they're valuing and what they're looking for as they look to partner with some of these groups that are involved in these businesses.
Again, as we mentioned throughout, this space is continuing to evolve. And as Dan said, there's over 50 private equity backed SUD platforms. There's about 10 ED platforms. And then there's a bunch of companies like a Sanford, whether at a smaller or larger scale, sort of do it all from inpatient through outpatient. But the industry is on the up and up. And I think it's really businesses like Sanford that are methodically doing things the right way, first and mostly for the community, and then locking hands with investors and other organizations. It's only a win-win. But David, Rae, thank you so much for your time today. It's been a pleasure. Think super highly of you and the team over at Sanford. Wish you guys the best of luck. From Provident standpoint, we will be at 2 addiction treatment focused conferences later this year. The first is BHB Invest, which is in Chicago in October, and then TCIV, which is in Scottsdale in November, which we're really looking forward to both here. But thanks again, everybody, and we'll catch you on the next episode.
Thank you very much.
Thank you.